khair. It's a pleasure to be here, and thank you, Dr. Samir and Dr. Walid, for this lovely invite. Honestly, Dr. Radwa and Dr. Hind really have paved the way for our next entity, and my talk is focusing on intermediate uveitis and how to approach it in a manner that we feel less stuck when we are faced with these cases. So, by definition, intermediate uveitis is a subset of uveitis in which the inflammation mainly involves the ciliary body, anterior vitreous, and peripheral retina. The Sun working group defined it as a subset of uveitis where the vitreous is the main site of inflammation. However, the presence of cystoid macular edema or peripheral vascular sheathing matinfiche in the diagnosis of intermediate uveitis. These cases usually have minimal or no anterior segment signs and usually no chorioretinal signs besides cystoid macular edema and peripheral vascular sheathing. It includes a wide variety of complex terminology, asymmetry and pars planitis, chronic cyclitis, peripheral uveitis, vitritis, cyclic chorioretinitis, and so on. But in essence, intermediate uveitis is vitritis mahawli. It may occur in association with systemic diseases. Most notable is the sarcoidosis and multiple sclerosis, or secondary to infections such as syphilis, TB, Lyme, toxoplasma toxophora, or it's deemed ocular only and it's attributed to an immunological pathogenesis, and at that point it's termed pars planitis. And I'll go into further definition and description later on. That is the idiopathic form of intermediate uveitis associated with vitritis with snow banks and snow birds. The clinical duration of intermediate uveitis is usually the longest. It's because it has a very insidious onset. Amongst all the anatomical types of uveitis, whether the anterior, posterior, pan, it has the least incidence. And the incidence varies according to the geographic location. It's usually more common in young adults between the 2nd and 4th decade. In children, it accounts to 16 to 33% of uveitis cases. In data that we combined from our clinic for Abu-Rish, we found that it only accounted for 2.5% of our cases. However, this was in 2020. I'm sure if we go back and look at our files in this year, we'll find that there's a huge surge in our cases of intermediate uveitis, mainly attributed to the ciliary body granuloma secondary to presumed rheumatoidal infections. So I'm sure this incidence is much higher now. Pars planitis, or idiopathic intermediate uveitis, usually accounts for 50% of cases of pediatric intermediate uveitis. However, once again, this goes back to the geographic location. Places such as India, they have a higher incidence of infectious uveitis. In our country, our percentage of infectious cases is also quite high. The clinical picture. So our symptoms vary greatly from anterior uveitis, where the patient is coming with redness and pain and photophobia, and being very insidious, very slow in onset. It's often asymptomatic. The patient may complain of moderate reduction of vision or floaters, mainly from the vitritis. A more significant loss of vision may be attributed to complications, of them being macular edema is the most common. So mainly this is a patient complaining of floaters. We examined them, as Durahan beautifully taught us how to do it. The anterior chamber is usually quiet. There isn't the associated ciliary rejection or the severe reaction that we see in anterior or pan uveitis. The cells in there are usually mild, rarely exceed 1 to 2 plus. In the pediatric age group, however, we may see a more severe or prominent anterior chamber reaction. In chronic cases, they usually develop broad band keratopathy. KPs are less common, but there may be small to medium-sized KP, or more commonly endothelial dusting. The hallmark of intermediate uveitis is vitritis, vitreous haze. In absence of vitreous haze, we're not going to diagnose the patient as intermediate uveitis. And it ranges from +1 to 4, as Durahan described in a much more eloquent manner than I can, with pictures that are way more beautiful. But however, we usually do not use the NIH grading of vitreous cells, we use the Sun grading of vitreous haze. How clearly can we see the posterior fold through this haziness? And then, subsequently, we can grade it 0, 1, 2, 3, or 4. Snowballs are commonly seen, and these are aggregates of exudates. We have an inflammatory reaction, they aggregate, they form these white, fluffy exudates, and they're usually, as Durahan mentioned, to the inferior vitreous, oris raptus, and we should have the patient look in all directions, dilate them widely, and try, if we can see through the vitreous haze, to detect these clots. Here we have snowball in the top left picture, surrounded by vitreous haze. In the bottom one, there's a larger aggregate of a snowball, a larger than snowball. In this picture, this angiography starts with quality. There's peripheral vascular sheathing in association with snowballs. Snow banking is less commonly seen. This is the coalescence of snowballs to form a plate. It's a fibroglial membrane, and it can extend circumferentially to involve the pars plana and the anterior retina with its complications that can occur. There can be traction, there can be associated symptomatic membrane. It's usually associated with more progressive and severe uveitis with a higher incidence of doing activity. So if our view allows, if there's the vitritis is so severe, we should examine very carefully the peripheral retina. We may see tortuosity of the vessels, sheathing of veins, all indicating that there is vasculitis. And this will help us in our further investigations and diagnosis. And often we have to rely on angiography as the vasculitis may not be clinically evident. But for instance, this is a patient with snowballs and vitritis. The fundus is hazy, but it's seen. And you can see in the inferior vascular sheathing, this patient was initially idiopathic, and later on, much longer course, developed a granulomatous anterior chamber reaction and was subsequently diagnosed as sarcoidosis. So as I mentioned before, pars planitis is the intermediate uveitis of unknown etiology, or immunological pathogenesis. And it primarily affects children and adolescents between the ages of 6 and 10. That is bilateral in 75% of patients with minimal anterior segment manifestations. But in children, the anterior chamber reaction may be more severe. Its most cardinal symptom, as in all cases of intermediate uveitis, is vitreous inflammation. And in 65% of cases, it's associated with snowballs and snowbags. In order to make things a little bit more complex, we can term it chronic cyclitis if there's no snowballs or snowbags. However, if it's just idiopathic intermediate uveitis or vitritis, it's usually termed pars planitis. The complications of cases of intermediate uveitis lie in its chronicity. The most common complication of intermediate uveitis and of anterior uveitis, and the most significant cause of visual loss, is macular edema. The associated secondary glaucoma, complicated cataracts, the retinal membrane, significant vascular affection compared to uveitis, which would be secondary neovascularization. Tractional detachment may develop in these patients from severe vitritis and vitreous traction, even causing peripheral retinal holes, peripheral neovascularization, optic disc edema, or inflammation. This is differential diagnosis or etiology of intermediate uveitis. So this idiopathic is at around 50%, and we turn them pars planitis. And then we need to define, are these infectious, non-infectious, or masquerade? Amongst the infections, very commonly have TB, syphilis, presumed pneumatotal, toxoplasma, toxocara, Lyme, non-infectious, multiple sclerosis, sarcoid, Behçet, and the masquerades we most importantly need to exclude is underlying malignancies. So multiple sclerosis is the most common systemic disease associated with intermediate uveitis, even though this is the most common ocular manifestation of MS, and should be suspected if it's a patient, especially a female in the ages between 20 and 40, presenting with significant vasculitis associated, pericarditis associated with intermediate uveitis, or if there's optic swelling. At this point, this patient definitely should be sent for an MRI. Actually, in most cases of intermediate uveitis, we do recommend it. Sarcoidosis also is associated with intermediate uveitis in 4 to 18% of cases, and if it has granulomatous reaction, it's always helpful in leading us down the path of this diagnosis. But what I want you to know is that many patients develop sarcoidosis after the onset of very severe vitritis, masking the view of the peripheral retina. At that point, an angiography, as Dr. Hind was noting, can be a great diagnostic tool. Even if we don't see it clinically, you can often see the fern-like capillary leakage from their vessels. On occasion, they're associated with inferior peripheral precipitates. These are a form of retinitis, which may confuse us with snowballs. Even though in visual patients we can see snowballs, these are usually on the surface of the retina, and they're not mobile. Patients use their eyes, they're not moving with the current of the vitreous. Very important to exclude is masquerade. The patient has history of surgery or trauma, and can attribute that to either perfect gas or endogenous endophthalmitis, or even an intraocular foreign body infarct plan. Intermediate uveitis may also be associated with retinitis pigmentosa, and if chronic and undiagnosed, long-standing intermediate uveitis may be confused with retinal disease. But moreover, more importantly, that we can't miss the malignancy. As Durahan mentioned, the cellular reaction to white deposits in the anterior chamber and vitreous in the infants may be highly suspicious of retinoblastoma, and at that point, I would rather do an MRI and better safe than sorry. The patients above 60 and presenting with vitritis that have had a partial response to steroids, we have to exclude primary intraocular lymphoma or associated primary CNS lymphoma, and its definitive diagnosis would be with the vitreous biopsy or cytological examination, histochemistry, or retinal biopsy. In cases of intermediate, our investigations include laboratory and imaging. In most patients, I recommend a CBC exclusion of sarcoidosis and TB being in the TB endemic patient country. Other ones you can be plus or minus. And if patients have sufficient view, I would recommend an angiography not to miss the associated peripheral vasculitis, as this will affect our choice of treatment. So this is a flowchart to help us approach a case of intermediate uveitis. You're faced with intermediate uveitis. Is it unilateral or bilateral? If it's unilateral, exclude an infection. Is this through canal water exposure? A UVM? Even in the absence of an AC granuloma is diagnosed. Then, once again, we are a TB endemic nation. We need to exclude TB, as Dr. mentioned, in almost all cases. Quantiferon, chest X-ray, and then we move on to the other infectious entities. If there are characteristic anterior segment signs indicating lupus, we can diagnose it clinically without further delving or burdening our patient. However, what we're most often faced with is the typical clinical picture. A young patient, bilateral vitritis, plus or minus snowballs and snow banking. This is corpusculitis or secondary to other investigations. If you allows, do an angiography, exclude the associated vasculitis, move on to exclude TB and sarcoidosis, and furthermore, if there's predominant vasculitis or pericarditis, and it's a young age patient, we want to exclude MS. If it's an older patient with predominant vitritis, we want to exclude lymphoma. Okay, treatment. Exclude infectious causes first, always in any case of uveitis. In cases of idiopathic intermediate uveitis or corpusculitis, do we need to treat all cases? Not necessary. However, in our country, with our socioeconomic restrictions, our lack of compliance or lack of availability to follow-up, this isn't exactly set in stone. They recommend that if the patient's vision is better than 612, the vitreous haze is mild, and there's no associated vasculitis, whether clinically or by angiography or associated complications, macular edema, glaucoma, we can observe. However, if the vision is worse than 612, with significant vitreous haze, vasculitis, even bilateral, there's a step-lateral approach for treatment. There's an associated anterior chamber reaction or not, we should proceed as recommended in treatment. Usually, first line of treatment is periocular steroids or subtendon steroid. If this person is not responsive within 2 to 3 injections, we introduce systemic steroids. Or if they're bilateral, we start with the bilateral injection and we can proceed with steroids in the first step. Immunomodulatory treatment can be combined with the first step of steroids, not waiting for the rapid tapering of steroids. From the onset, we can start immunosuppressive treatment. And in children, the is usually of high safety profile. Biologics can be introduced, especially in cases adalimumab or Humira has been more efficient intermediate uveitis for preventing recurrence and maintaining remission. However, we need to note that anti-TNF alpha agents themselves may be predisposed to decombination. And we already mentioned that MS is the most common systemic association of intermediate uveitis. A vitrectomy may be considered as a fourth step in non-clearing vitritis, associated hemorrhage, and retinal detachment, or even to obtain a sample for diagnostic purposes, for instance, when you come with the old lady above 60 with predominant vitritis. Cryotherapy is previously used for regression of neovascularization, but it in itself may cause ventricular contraction. Laser photocoagulation may be recommended in cases of severe vasculitis and peripheral ischemia and neovascularization. And I ask you not to forget that in children, especially unilateral, exclude the infectious ends. Presumed treatment-total intermediate uveitis, toxoplasmosis, toxicara. These patients are usually free of systemic findings. In adults and granulomatosis anterior uveitis, it saves us a lot of our pathways, and we should always go down the line of sarcoidosis.